late, I think so, but maybe all are feeling sleepy. But I'll make it as crisp and clear as possible with practical slides so that everyone will be awake to listen to my talk. On left hand side is the Harfield Hospital from where I got trained, and right hand side is the Apollo Hospital where I practice ECMO. The topic of the day is, as Pranay also said, it's ECMO in ICU setup. So contents of my talk will be the ECMO in usages in lung transplantation, heart transplantation, pre and post-op, and discussions about the current literature and our experience. ECMO in ICU for lung transplantation. I have categorized as the pre and post. So also I'll be comparing mechanical ventilation to the ECMO as a bridge to transplantation. ECMO as a bridge to transplantation, which means patient awaiting lung transplantation, we are initiating ECMO and awaiting for a lung transplant. Before going to details, we should know what are the diseases which needs lung transplantation. They are restrictive lung diseases like ILDs, obstructive lung diseases, suppurative lung diseases, and pulmonary vascular diseases. All these diseases will not progress gradually. Some of them will have exaggeration and there will be a sudden deterioration. What this paper says is ECMO is a life-saving option for the ILD, provided there is an option for transplantation. If the patient doesn't have is not a candidate for transplantation, like they are going to be on having a severe infection or malignancy, they are not candidate for transplantation. In those patients, there is no point in initiating the ECMO. So the patients who are candidates for transplantation, we have to initiate ECMO, and it has got a very good result. So as I already mentioned, if these diseases, the above mentioned 4 diseases progresses, they don't do very well. The only therapy in front of us will be lung transplant, and disease progression is not always gradual. Most often it is sudden. And Western countries and India, if you compare, means Western countries patients present to us very early so that we can list them and then wait for transplantation, and they get an organ before thinking about ECMO. But India, the patients have been referred very late, almost on the verge of ECMO. So chance of ECMO here are higher than in the Western countries. If during the awaiting period, if the patient deteriorates, there are only 2 options in front of us: mechanically ventilate them and tracheostomy them, and then wait for an organ, and or else the ECMO. The advantage of mechanical ventilation is there is no anticoagulation, so the bleeding chance during the transplantation will be less. But during the if patient is going to be on mechanical ventilator, then the volumotrauma and barotrauma and the chance of infection of the lung, like VAP and other things, are significantly higher, which are not there in the ECMO. Also, we can't maintain a very good saturation in mechanical ventilation, whereas we can maintain a very good saturation in ECMO, especially in dual lumen single venous cannula, where you can mobilize the patient and do all kinds of physiotherapies. If the patient of these classes, above mentioned classes, deteriorates, we have to see whether these are all potential candidates for transplantation. Otherwise, also, if the patient deteriorates, we have to see whether is there any treatable causes like infection or pulmonary embolism in this subset of patients who are awaiting lung transplantation. If there is a major infection or pulmonary embolism, first treat them if feasible. If they is clinically stable, treatment of that alone can be a cure for the patient, and you can maintain them without mechanical ventilation or ECMO. But if you are forced to, then you have to put them on mechanical ventilation ECMO, assess them if they have any treatable causes, and treat it, so that we can get them off the mechanical ventilation and ECMO. That should be our first option. If it is early due to exaggeration, then we can give some treatment for exaggeration like high-dose steroids and wait for it. Try to remove the patient from mechanical ventilation ECMO as far as possible before proceeding with transplantation. If that is not an option, there is no other way. We have to keep the patient on ECMO till transplantation. Let us see the disadvantages of mechanical ventilation. It's a volumotrauma, barotrauma, and atlectic trauma. This all happens in the ventilation, which will not happen in a ECMO or VAP, as I already mentioned to you. And also increased pressure effect on the usually has a deleterious effect on the right heart. We maintain too long a period in the mechanical ventilation, the right heart can get a hit, and the patient may be forced to have a heart and lung transplantation rather than lung transplantation alone. And increased FiO2 can cause ototoxicity, This is only a debatable thing in a patient who is waiting for a lung transplantation, because anyway his lung is going to be transplanted. During mechanical ventilation, the model of these patients approach to 70 to 90% if transplant is not an option. And the outcome of the lung transplantation in mechanical ventilation is poor when compared to ECMO. Fugner in 2012 compared the mechanical ventilation with the ECMO and proceeding for a transplantation. He showed a survival of only 50% in 6 months in patients who are bridged with mechanical ventilator, as opposed to 80% with ECMO, which is statistically significant. Factors to be considered before putting the patient on ECMO are whether the condition for which we are putting is reversible, and whether the patient is infected, renal function is normal or recoverable, liver function is normal or recoverable, chance of bleeding, malignancy, TPG, and also TPG means transpulmonary gradient, and also RV function, and the finance, of course. Indication for bridge to transplantation are refractory hypoxemia, refractory hypercapnia, refractory RV failure, or a combination of above, which are all the indication for lung transplantation. Observed contraindication is like contraindication for any other ECMO patient, relative or allocentrism, which makes the patient prone for rejection. Also, if the vascular access is limited, like in pulmonary hypertension patients, especially secondary pulmonary hypertension patients, these patients will have thrombosed vessels, so the vascular access will be limited. So these are all relative contraindications. Factors in favor of survivable are age less than 50 years, and normal or marginally elevated bilirubin, normal or marginally elevated pulmonary artery pressure, less than 14-day duration of ECMO, because more than 14 days chance of infection and bleeding issues are higher. The SOFA score more less than 6, non-invasive ventilation, or a patient is extubated, has got a better prognosis. Ability to participate in the physical therapy is also very important. Unfavorable factors are age more than 60 years, raised bilirubin or raised pulmonary artery pressure, prolonged stay on the ECMO or mechanical ventilation, immobile and frail patients, SOFA score more than 9, major bleeding or infection which the patient has encountered during the waiting period on ECMO, retransplant with a retransplant interval of less than 1 year, because these subset of patients redo surgery, and also chance of rejection is higher. This is the graph which shows ECMO, how it has developed from 1962 till now. So initially, the first reported use of ECMO was in 1972, but with that, it is improving a lot. And then I think with a lot of improvement in the circuits and the priming volume has been reduced now, and the heparin coating and other things, it has shown a marked improvement. And also the centrifugal pump introduction also has changed. And also each and every center's experience has improved, especially after this H1N1 influenza outbreak. Initially, the bridge to transplant results were poor before 2000, but after 2000, because of a lot of innovations in the circuit, the results are good now. And also the usage of dual lumen cannula, like Avalon cannula, has an improved chance of survival, because their participation in the physical therapy is more. This is the study. There are various studies which supports ECMO, and there are various some studies which supports mechanical ventilation during the waiting period. Some of the studies are showing no difference, but ultimately more number of papers are showing results in favor of ECMO than mechanical ventilation. So once a patient is placed on ECMO, first try to treat the treatable cause and get him off the ECMO. If that is not possible, get him off the ventilator and allow him to participate in the physiotherapy, so that his muscles and all will be taut and frailty will be reduced. So we don't know when the organ is going to come. That is always unpredictable. So till that time, keep the muscle tissues functioning well. So AVIC ECMO helps in oral feed, improved participation of the patient in the rehabilitation, and also he can communicate with others the needs of him. And also, once they're transplanted, this patient has a better result because they are not kept sedated and then paralyzed. Single lumen cannula can be with Avalon, where we use percutaneous technique or auriculated cannulas. This is the one which we can use only as a direct method. So we open the neck and then introduced it and then placed it. Nowadays, Avalon is also available here. Avalon as such is not available here, but regionally some make like Avalon is available nowadays. We are using that. This is one of the patient awaiting lung transplantation on single lumen cannula. And this is one of our ventilated patient on ECMO awaiting lung transplant, but later she got extubated. Also, VV ECMO is also a boon to us when considering transfer of one patient from one part of the world to the other part of the world. This is a patient who was in UAE and then initiated for bronchiectasis. They shifted the patient to Apollo Chennai for lung transplantation successfully. But shifting the patient on mechanical ventilation is always risky. But shifting with ECMO is relatively safer, especially in these patients who have end-stage lung diseases. And this is one of our patients who had cardiac arrest during the waiting period for lung transplantation. So CPR given and then VA ECMO started. And then also the cardiac function didn't come up. So we placed another cannula in the neck. So VAV ECMO. Then the heart picked up and then waited for transplantation. Unfortunately, we lost this patient because of sepsis during the waiting period. This is the ABG, which was around PCO to around 109. And immediately after, ECMO, it is reduced to 66 and gradually dropped to around 53. Post-operative, we use ECMO for primary graft dysfunction or sepsis. These are the two important causes. Rarely, we are forced to support the heart in case of idiopathic pulmonary hypertension where the RV function was borderline. This is the various grades of PGD. Usually, PGD of grade 3 needs ECMO. Grade 0, 1, and 2 can be managed with NAV or mechanical ventilation. So this paper states that ECMO in post-lung transplantation for PGD has got a very good result. Only 5% of these patients needs a rescue ECMO. 96% of the patients can be weaned off VV ECMO. And the survival rate of 30-day survival is around 82%. And 1 year survival is around 64%, which is very good. And this paper says that when the ECMO is initiated for PGD, the results are good compared to ECMO initiated for infection. So you can see the 1 year survival post PGD is almost around 41%, but 1 year survival following sepsis is only around 3%. So in a nutshell, the ECMO initiation in the post PGD, the results are good than post sepsis. This is one of a patient who had a PGD. So we placed ECMO. In 36 hours, the lungs cleared and they're able to remove the ECMO. This is a pre-ECMO and this is a post-ECMO, the same patient. It's a lady who had this PGD and went home back, fine. And we have done post-sepsis also with ECMO with good results. And this is a patient who was in situs inversus totalis. So, 23-year-old girl with situs inversus totalis for heart and lung transplantation. And she had a very stormy post-operative course. This is a pre-op chest X-ray where you can see the chest X-ray in the right side of the chest. Sorry, heart in the right side of the chest. And this is the patient had a left side SVC and IVC and the right aorta. So it was a challenging transplantation. And this is the pre and the post. Post donors will be having the left side heart only. So we have transplanted this. And there is some issue in the stitching and all, which was challenging, but we did it. And on day 5, she developed a florid infection in the chest. We were able to identify the cause and then treat it appropriately. It's a gram-negative sepsis because of Klebsiella. Fortunately, it is a sensitive bug. And then it's a day 8 of VV ECMO, day 11, and day 12 of VV ECMO. You can see the cannula coming through the left side of the IVC and then turning to the right. And On day 13, we have removed the patient off ECMO and she did well post ECMO removal. This is the X-ray before, just before ECMO, and this after removal. Few word about COVID and ICU ECMOs. In our experience in the COVID second wave, the end-stage lung failure patients are referred for lung transplantation, but we waited for some more time and then they have recovered. So the crux in a nutshell, like whichever patient are referred for a transplantation also, if you think of transplantation, do a CT scan. If there are still recoverable chances, then worth waiting. Some patients recover even after 6 months also. So those patients are went home well and doing fine. And before proceeding with lung transplantation, make sure the CT scan shows irreversible changes in the lungs. ECMO in ICU, in heart transplant. Now the lung transplant is over. Now coming to the heart transplantation. The pre-op ECMO usages depends on the Intermax scoring. Post-op mainly it is used for primary graft dysfunction. And unlike lungs, which only the ECMO is the only machine that is available to rescue this patient, heart has got a lot of other choices like IABP, left ventricular assist device, short-term left ventricular assist device, or percutaneous device like Impella or total artificial heart, apart from the ECMO. So these are all the short-term devices which are used, especially only the heart needs the support. So blood will be sucked from the left atrium and given back to the aorta. Most of the patients will be stable with that. But if it is going to be associated with the lung issues like pulmonary edema and other things, then the ECMO is needed. Short-term LVADs, mechanical circulatory supports, IABP can be used 1 to 7 days, but it can be used after that also. The same thing applies to all other things, but general is this one. Impella is 1 to 12 days. Stand-up heart can be used up to 13 days, ECMO to 14 days. But we have used VECMO up to around, 4 weeks. And then long-term are heart rate and HVAD 10 years to see something about the short-term devices, the long-term devices. Short-term LVAD versus ECMO. ECMO is indicated if the patient needs heart and lung support. And in ECMO, there are an oxygenator, and ECMO doesn't decompress LV sufficiently, which is not the case in left ventricular assist device, where ECMO, the left heart is nicely decompressed, and there is a chance for recovery and less chance for pulmonary edema. And blood trauma is higher in ECMO because of the presence of oxygenator. And factors influence the outcome are Intermax score and duration of ECMO, renal and liver status, blood product usage, and ECPR. Less than 50% of these patients undergo heart transplantation. Most of the people equal number of patients will be losing during the waiting period. So this is the Intermax score. In short, Intermax score 1 is a very sick patient. Intermax 7 is somewhat a stable patient. 4 or less than 4, we need to consider this ECMO if lung involvement is also there. So a few examples. This is a patient who had cardiac arrest and then resuscitation, and we were called for. So we initiated the ECMO, and then this is the ABG. pH is around 6.986, which improved and to around 7.473. And then after a few days' time, we are able to remove the ECMO because there are some viable tissues, so we are able to remove. Then he was placed on IABP. There's another patient who had a central ECMO in ICU, dilated cardiomyopathy patient. This was awaiting lung transplantation, heart transplantation. First, we attended peripheral cannulation. We failed it. After open treating also, because of large amount of vasopressin adrenaline and also noradrenaline, the femoral artery was in spasm. So we were forced to open the chest and then introduce the cannula. This is the aortic and right atrial cannula. And then we waited for the heart. And it's always not rosy. And this patient who had a previous CABG, now with heart failure and end-stage heart failure, awaiting ECMO, arrested in the ward, and we tried to resuscitate with an ECMO, but we couldn't cannulate the femoral artery because it is also atherosclerotic, and we couldn't establish the flow. And if the patient gives time, he is the one who was in the Intermax score 2, So we took him to the theater and then placed femoral vein cannulation through ultrasound guided and femoral axillary artery graft cannulation, and we tunnel the axillary graft through the intraclavicular region, and then supported him for and divided him for a transplantation. He was on CRRT, but later his kidney improved. Within 5 days' time, luckily he got the heart. He was AB positive, so we proceeded with the transplantation. Also, ECMO we initiate, and then we can use impeller device also to decompress it. It's both devices will help these patients. Impeller was before impeller we need to place the LV vein. Now because of impeller we can place the impeller and decompress the LV. That can reduce the volume or else lung congestion. In our experience, bridge to transplantation we have done around 13. 9 were weaned off successfully from the ECMO in OT, which is around 69%. 4 died while waiting. In post-op, 8 we did 8. 6 survived, which is around 75%, and 2 died. In summary, ECMO is a very useful tool in managing pre and post transplanted patients. Usage is more in lung than the heart transplantation. Mortality of ECMO patient awaiting heart transplantation, unlike lung transplantation, is higher. Well, thank you very much from our team. Do you have any questions?